All right, our next presenter is Dr. Bethwel Raore. Dr. Raore is a good friend of mine and one of our um, founders of the Kisumu Neuroscience Initiative. Dr. Bethwel is actually coming to us. He's a neurosurgeon in Atlanta, but he's coming to us today from Kisumu, Kenya. Dr. Bethwel, welcome. Good to see you. Can we? Your microphone's not on.
All right, can you hear me? All right, thanks, Victor. Thanks, Dr. Karas and everyone who's organized our virtual meeting. Um, I'm sitting in Kisumu right now, where we would rather be having a live meeting, but as we all know, the situation with COVID and everything, it's thrown a wrench on all our meetings. I think previous to COVID, we were thinking this would have been our fourth Kisumu Neurosurgery Symposium, but regardless, I think we've made it work as we need to make it work. So I am in Kisumu right now. We are doing a neurosurgery camp. And, when we come for the camp, we don't know most times what kind of cases we're going to encounter. And, you know, I was asked to talk of sagittal balance, uh, which has turned out to be very appropriate on this visit. So I'll just go through a few pelvic parameters. This talk is not going to be your full lecture on sagittal balance for the time that that it's been allotted. But I'm going to talk about a few terminologies that you should be well aware of when you're discussing sagittal balance. Um, at this period of time, the concerns of sagittal balance and how much as a spine surgeon you should you should keep a good concern of them is actually significant. I think in years past, we did surgeries and fusions without any thought of balance, but it's been shown that you know the recovery of patients and the ODI scores have improved in patients who their surgical balance um, in patients who the surgeon has attempted to reduce them to an appropriate surgical balance for their age. So some of the terminologies are number one is the lambulodisis, pelvic incidence, pelvic tilt, sacral slope, truncal inclination, and surgical vertical axis. And I'll attempt to define them coming up. So the lambulodisis, that's the angle between the top of S1 and the top of L5. The normal range is about 55 to 65 degrees. Your most doses is between L5 and S1. That's about 32 degrees. If you took L4 and L5, that's 16 degrees. 80% of the lordosis is between L4 and L5. Pelvic incidence is another terminology. For pelvic incidence, it's the angle between between the center of the femoral heads. If you take a line that joins both femoral heads and you take that line direct to the center of S1, and then you take a line perpendicular to S1, that's your pelvic incidence. This value is defined for every patient. This value does not change. Now, for your lumbar lordosis, it will change with degenerative disease. The other term is pelvic tilt. So pelvic tilt, if you take a vertical line from the bifemoral line and then another line to the midpoint of S1. This pelvic tilt, this is a measurement that can be affected by the positioning of the patient, can also be affected by degenerative disease. So if you look at this picture on the left side, it shows you a patient who has degenerative disease, but they've tilted anteriorly to increase what is called their SVA, which I'll define in a second. But they don't have a pelvic tilt. But in order for them to stand straight, they have to compensate by retroflexing their pelvis so that give them a large pelvic tilt.
You hear me okay? This is Dr. Karras.
Yes, I can hear you. Can you hear me?
I can hear you. We can see you well. We can't see your screen. It had gone off. Is your slides show up on your screen?
Yes.
All right. You can continue with your presentation, and they'll keep working on bringing that up for us on the live stream.
You'll need to share your slides again, please.
Dr. Raore, we need to share your slides. Okay,
Yes.
there we go.
Are you seeing them now? All right. So if we take the three pelvic parameters we've talked about, the pelvic incidence, the pelvic tilt, and the sacral slope. Actually, let me talk about sacral slope again. Yeah. So the sacral slope, if you take a line right on top of S1 and an horizontal line, the change in the degree, that is the sacral slope. Again, sacral slope can be affected by degenerative disease, can also be affected by patient positioning. It's normally calculated that your pelvic incidence is the sum of your pelvic tilt and your sacral slope. The other two terms, SVA, the sagittal vertical axis, and truncal inclination. The SVA is basically if you take a plumb line and place it at C7, it's the distance between where the plumb line, it's the distance between the distance of the plumb line to the posterior part of the S1. Normally, you don't want that to be more than 10 degrees. The truncal inclination is if you take a perpendicular line from the floor to T1, and if you put a plumb line at T1, the difference of that angle, that's the truncal inclination. When you're talking of the sagittal balance, it affects the cervical, the thoracic, and the lumbar spine. And therefore, as a spine surgeon, you cannot just think of the lumbar spine. You have to think of the thoracic spine and you have to think of the cervical spine, because deficiencies on any part of the spine will directly affect the alignment of the adjacent parts. The lumbosacral lordosis is about 30 degrees more than the thoracic kyphosis. The normal thoracic kyphosis is 20 to 40 degrees. The normal lumbar lordosis is 30 to 7 degrees. Now, these curves are proportional, and on a perfect sagittal balance, your SVA should be about 5, as you can see in this picture. Now, after several years of research, there's these three um, the lambulodisis, the SVA, and the pelvic tilt, they've become the measurements which have been shown to correlate with the worst degrees of disability. For most people, the quick number, which is the pelvic incidence and the lambulodisis, the mismatch of that, of greater than 11 degrees, has been shown to correlate with a lot of disability and pain. Your SVA, with age, most people, with age and degenerative disease, the SVA increases. As the lambulodisis is getting less, the SVA gets more. And at 47 millimeters of SVA, there's severe disability. And the pelvic tilt of 22 degrees also correlates with significant disability. As you can see, this gentleman in the picture has engaged the compensatory mechanisms. They're losing the lambulodisis. Therefore, they're compensating with the thoracic hypokyphosis. Their thoracic curvature is getting less. As you can see, their goal is to look straight up. As they're trying, as they're falling forward, they're not able to look straight up. So as they struggle to look straight up, they will have hypolordosis of the cervical spine. They're going to retrovert their pelvis, and they're going to bend their knees. Now, for them to do all of this, it takes a lot of energy. The paravertebral muscles will cause a lot of axial back pain. That's why, for most people, as the lambulodisis gets lost, they'll definitely be, they'll pick a cane or they pick some type of a walker or some type of assistance, and they're looking down most of the time. So at the end of the first week in Kisumu, we've seen several patients. We've done about 20 surgeries, of which I'd say the majority has been spine surgery. These two pictures, one on the left side and one on the right side, are, I think, basically typical of what we have seen. There's a lot of spine disease, which has been underdiagnosed for several, for several cases. They've been diagnosed, but patients have not had the resources to have any intervention. On the right side, this patient has a pretty decent, the lambulodisis is pretty decent. Again, without the imaging to look at the femoral heads or the rest of the spine, we've not been able to calculate all the spine parameters. But as we can appreciate, they have a slight L4, L5 spondylolisthesis. They have significant central canal stenosis. And this is one patient who we've just done a short fusion without an inner body from L4 to S1 and a decompression. On the left side, this is multi-level stenosis, multi-level degenerative disc disease. This is a patient who, back in Atlanta, we would get a full spine X-ray that includes the pelvis with all the calculations. Now, depending on the resources you have, you can calculate the correction before you even have the patient in the operating room. If you use some vendors, like the Medtronic vendors. You can even have your implants and your antibodies customed for the correction that you intend to give to this patient. But in this case, we've been able to do several pedicle screws. We did not have the appropriate inner bodies, but with the pedicle screws and the decompression, we've addressed all the concerns for the radicular pain and the neurogenic claudication that the patient has presented with. And I believe we will also have addressed an element of the actual back pain. Now, just with the pedicle screws, with a significant work of taking down most of the facets and bending the rod appropriately, I believe we have created, we've improved on the lumbar lordosis, but for sure, I don't think we've corrected it to the level that it should be corrected. However, in our setting at this point, this is what we have done. So I'm going to stop there for any questions about our current event in Kisumu.
Very good. So it sounds like you're getting, in your current trip there, more spine than brain. Is that correct?
Yes.
And is that a function of patients' word of mouth, advertise? What is it that's bringing patients in, or has that always been the case, and now we have a program there in Kisumu that can address these things?
Well, I think it's a function of both. There's word of mouth going out. There is some previous advertisement, and the neurosurgery clinic here with the great work that Dr. Gutha and Dr. Adero have done. They've screened a lot of patients, and previously a lot of people have had spine disease. They've just not had a place to go or even known that these are things that can be taken care of. So I don't think that this is a new phenomenon. I think this is it's just been discovered at this time, and so people are coming out, and they're coming to have their back assessed and taken care of.
And Dr. Agutha had brought up the issue of referring physicians, knowing that you're there and what you do. Do you feel like, this goes back to a previous question, that neurosurgery now is the specialty that's being referred to for spine, or are there orthopedic surgeons in Kisumu also performing these same procedures?
Well, to my knowledge, Dr. Adero is the orthopedic surgeon. I'm not aware, maybe Dr. Gutha could correct me, but I'm not aware of an orthopedic surgeon in Kisumu who's doing this kind of work. And both Dr. Adero and Dr. Gutha have been with me this week and bringing all the patients who they have screened over the last several weeks and even months. So I think we've had a really good camp with, sharing and skills transfer. Dr. Gutha, anything you want to add on this?
No, just to say that there are a number of orthopedic surgeons in Kisumu, but there isn't any who've been doing spine surgery specifically, and certainly not instrumented fusion.
Okay, very good. And do you foresee a situation in which neurosurgery begins also educating the orthopedic surgery residents in spine over time?
Yes, we would certainly hope so. The community of orthopedic residents is actually larger than that of the neurosurgical residents, and some have an interest in spine surgery. So the hope is that whenever training opportunities are available, they can be roped into the community of spine surgeons. In Nairobi, there are a few orthopedic spine surgeons, but we don't have any in Kisumu.
Okay. A question for Dr. Raore. Just from your first trip. You've made multiple trips to Kenya now since we started this program. From your first trip to now, can you just give us an insight into what do you think is working, what is not working, what do you think is, well, how have we improved from the time we started to now?
Well, thank you for that question, Victor. I think it's a great question. Going back to 2017, when we were on a conference call talking about Kisumu and availability of the neurosurgery, and us, getting together and deciding that we needed to make a step. Obviously we started with a hospital that had not seen the kind of work that we did on, in that year. And our goal at that point was to bring neurosurgery from an event to neurosurgery to being a daily happening, to being a daily occurrence. And, when I look back, I think we've made a lot of strides. I think on this trip, this is, I'd say, my most exciting trip. And it's because of two things. Because number one, I've met Dr. Guth and I've met Dr. Ardero. Dr. Guth is a graduate of the Nairobi program, but he decided to come to Kisumu. And Dr. Ardero is also a recent orthopedic surgeon who is also in Kisumu. And previously we've all made trips where we come and we do a lot of cases. But if you think of all the cases that Dr. Dare and Dr. Guther are going to be able to accomplish, it's going to be much, it's going to be way more significant. And then if you look at the operating room and you look at the staff in the operating room who, when we started, had not seen some of the instruments, I have to say right now that the team I brought, there are cases where they feel bored because they're just sitting around. And they're sitting around because the local operating room staff is basically running the room, right? And honestly, I've told them that that's what we want. We want them to come to Kisumu and be bored because the folks here are scrubbing those cases and are doing those cases. So, if I think of where we started and where we are right now, Victor, team, Dr. Lunya, and everyone else who's supported this vision, I am immensely grateful. I'm immensely grateful. And the word is out, and the word is out and people are coming in and back pain is being taken care of and brain tumors are being addressed. And, I think right now the big challenge for all of us is to support Dr. Guth. And we can, we are going to have other conversations where how to help and champion for Dr. Guth for him to be successful. Because his presence here is what we want, and hopefully we attract some more people, There's a resident right now who's also at the camp. He's a COSEXA resident who will be coming back to the Aga Khan Hospital in Kisumu maybe in, I think, another 3 or 4 years. But, if another 3 or 4 years we get a second or even a third person in Kisumu, I think we're gratefully marching towards neurosurgery not being an event in Kisumu, but neurosurgery being the daily occurrence. So, Victor, to wrap up this question, there's a lot of difference, and I think we've made a small dent, and I think the dent what will keep the dent alive is how much skills we transfer and how much support we transfer, and everything from the trips and to this symposium just helping put Kisumu on the map for neurosurgery.
Great, thank you. Thank you, Dr. Raore.